So next up we've got Cristian Costas. He's a gastroenterology dietitian specialising in celiac disease, and he works at Bradford Teaching Hospitals at the moment. He currently runs a dietetic-led celiac service in his hospital with the support of gastroenterologists, and has built the service over the last 2.5 years. He's been awarded with the National Guts UK and Dr Falk Dietitian Recognition Award for improving patient care in gastroenterology through his dietetic-led celiac service in Bradford. And I think from working with him on the gastroenterology specialist group, he seems to have more hours in a day than the rest of us. So thanks so much for coming to speak today on your benefits of a dietetic-led celiac service.
Thank you, thanks for the introduction, and it's a true honour to be able to speak here today in Sheffield. And definitely I want to focus this talk on the benefits of a dietetic-led celiac service, because I really think that when, as dietitians, we're managing the great majority of these celiac patients, but we still have the essential support of our gastroenterologist, ultimately this is the most successful formula we have to improve patient outcomes, make services more efficient, and save NHS money. And you can see a very happy patient at the top there, so that's what we're all aiming for. So I think it's important to say that historically the management of celiac disease has kind of fallen to gastroenterologists, then celiac nurses have also supported them. But I think over time the input from dietitians has severely lagged behind, where at this day and age we still have very few dietetic-led celiac services, and the services that aren't dietetic-led have got input from dietitians which can be quite sporadic and I think inadequate, because patients get few appointments with them. So essentially what we wanted to do in Bradford was flip this model around and turn it into a service where the dietitian was a true specialist, had extended roles, and that was my role, to actually start to order bloods, assess patients with bone scans, and be able to take over the full care of these patients. So the thing that facilitated this was having a strong MDT with our gastroenterologist, where I could ask them questions about patients. They could sit in clinic if needed. If we had challenging patients too, I could refer to them, they could refer to me. And this has really facilitated things for gastroenterologists, and I think this is really the future of celiac disease, if we manage to get this, make this consistent. And it's also put us in a prime position with the changes that have happened with the pandemic. So when the non-biopsy approach was published by the BSG in June 2020, we started to implement it from August 2020, and the data we have until May 2021, we've had 41 patients diagnosed, and out of these 41 patients, we've had 68% who have just required serology. So they've had their serology done with their GP, and they've come straight into the celiac clinic with myself, and they haven't needed any input from secondary care, from gastroenterologists. If anything, maybe a couple of questions to a gastroenterologist, but no appointments or anything like that. And for the rest of them, the other 32%, they've needed some input from the gastroenterologist to request the endoscopy. But then with the pandemic, things have been so busy for gastroenterologists that they've really trusted this service even further, and they've just headed straight into the dietitian-led clinic. So I think this really shows that we can take that step further and get involved from the start and be the first professional that these patients see when they're diagnosed, and really take ownership of that. And I think gastroenterologists appreciate that, and it helps the patient. So, and I'm going to explain why. So I think there's a lot of benefits with having a I might be a bit biased, there's a lot of benefits with having a dietetic-led celiac service, but I think one of the things is when we're so involved, we can really support patients with getting the right test. So I've had, patients referred who've just had a biopsy, and we can say, no, this patient needs serology too. A biopsy is definitely not enough to diagnose someone with celiac disease. Then also we can explain the diagnosis in depth and explain the management. And I think it's clear, the research shows that patients need to understand the importance of this condition to know how important it is to follow the diet. And we need to go into detail with patients with things like teaching them how to read food labels. I would say the great majority of patients I see don't fully understand how to read a food label. So how can they know they're following the diet or not? And if they don't know how to read a food label, they're more likely to over-restrict their diet or under-restrict it. So we need to help them to get the balance, and this takes time and education. I think also we can use our skills to identify involuntary gluten ingestion, which most of us know is one of the main causes for non-responsive celiac disease. So we can ask questions about cross-contamination, we can check how they're reading these food labels and see what sort of habits they have. And then we can also help with other causes of non-responsive celiac disease, where we can help them with other challenges, things like lactose intolerance, for example, which can be quite common, reflux symptoms, and things like constipation, which can often happen when patients start the diet. So we can help with a lot of symptoms that they'll present and get them treated in clinic without having to wait for further investigations. And we can obviously personalize the diet, so we might have vegan or vegetarian diet patients, for example, and then we can also take into account things like diabetes, dyslipidemia, other comorbidities, because patients rarely present just with celiac disease. They tend to have other challenges. And really, we understand when a patient's following the diet and they're getting symptoms that they shouldn't be getting. And that's where we can refer to gastroenterologists, and our assessment can really help guide investigation, especially during the pandemic, where it's more challenging to get things like endoscopies done in some services. So this can be a really good way to manage things. And obviously, we can order bloods, assess patients for bone scans too, and then we can act on a lot of these bloods. And if things are a bit more complicated, we can ask our gastroenterologist, but we can really own the whole vitamin and mineral supplementation, which a lot of patients have questions about. Patients have a lot of questions about vitamin D, and we can really support them with this and take ownership of that. And we can really help to optimize bone health through these sorts of things. We can talk about lifestyle modifications. And in fact, when I took over the celiac service, we had about 100 patients who were overdue a repeat DEXA bone scan. So really, we can oversee the whole care for celiac disease, not just looking at gluten ingestion, but optimizing their health as a whole. And I think this links up a lot with what Dave's been talking about. And I think dietitians play an important role in monitoring for celiac disease in a non-invasive way, because as good as serology can be at diagnosis, it's got some serious questions we need to ask about when we're talking about follow-up. So that paper is a really good systematic review from Sylvester and colleagues, shown that absolutely the sensitivity of serology on follow-up can be as lower than 50%. So really, a negative TTG, it does definitely not mean there's not active celiac disease or that the patient's following the gluten-free diet. There's some interesting research after that which showed that, yes, by using validated adherence questionnaires in combination, this could potentially be superior to serology, but there's some important limitations with these questionnaires where they mainly ask about symptoms and ask the patient if they're eating gluten. And one of the biggest challenges for patients is that they can be eating gluten without knowing it. And that's why we need our skills and expertise in clinic with these patients, where we can unpick a lot of that. Yes, a dietetic review is not 100% accurate, it's a snapshot, but understanding patients' habits gives us a very good idea of how they're doing things, and we can unpick a lot of things. And obviously, we've got to mention that there's this relatively new player in the game, which has been mentioned previously, which is the gluten immunogenic peptides, which can be found in urine and stools. And I think it's important to mention that whilst they're emerging, and I think they can be very useful, they still just tell us about potential gluten ingestion or transgression, but they don't tell us what that source is. So that patient still needs to go to a dietitian to understand what they're doing wrong. And obviously, we've got the gold standard, which is an endoscopy and duodenal biopsy. And, you know, that is very useful. But again, with the pandemic, these things can be challenging in services. And, you know, if we can get these patients seen by a dietitian, they've got ongoing symptoms, and we identify gluten in their diet, we can avoid unnecessary procedures. We can avoid an unnecessary TTG or an unnecessary endoscopy for some of these patients. So I think it's not about selecting one of these over another. It's about understanding what role they all play and how we can integrate them into services. So through this input with dietitians, I think we can save a lot of money for the NHS. So some of the cost savings we identified was for patients, for example, we did 300 less TTGs in the first 13 months. And from the data we had from our trust, a negative TTG is about £4.50. A positive one is about £20. So you can start to add up things there. And also there was a lot of patients who were getting referred by gastroenterologists with ongoing symptoms, and they just asked us to assess the patient's diet and see if they were following the diet or we needed to do anything differently. And we actually identified that 8 of these patients were not following the diet, and we could actually correct their habits, help them, educate them, and they did not need a repeat endoscopy. So that saves an invasive procedure and saves money for the NHS too. And what we identified was, with my role, mainly I was taking over the caseload of the celiac nurse so she could do more endoscopies. But the gastroenterologist realized that this was very useful, and they started to discharge a lot more patients. So we had 66 additional patients that they discharged to the dietetic-led celiac service. And really, we can quantify this in 2 ways: time saved for them in clinic, or money saved by less appointments. And if it's through money, it would be something like £204 for a new appointment, £80 for a review appointment. So really, if we add all of these up, within the first 13 months, we had some estimated cost savings of £15,000 to £20,000. And, that can be a significant amount of money to pay for that dietitian. And there's a lot of cost savings there that we couldn't quantify, that are difficult to quantify. So I think it's also important to understand what gastroenterologists think about this sort of service. And this is some feedback from our lead celiac consultant gastroenterologist, Dr. Rabb. So he said, the assessment offered in the celiac clinic is thorough and gives the gastroenterologist reassurance that patients are receiving expert advice and that adherence is being monitored far more reliably than by intermittent serology testing and unstructured clinic reviews. Going forward, it's likely that this approach builds confidence in the patient's ability to manage their condition, reducing the need for ongoing contact with secondary care. Fundamentally, this is a time and financially efficient service. This model of work takes into account the reality that a consultant gastroenterologist is not usually the best person to guide a patient in the day-to-day management of celiac disease, but can play a useful role as part of this MDT. So I think what Dr. Rabb is trying to say here is that when as dietitians we take that step forward and help patients with diet, because most patients, the challenges are going to be around diet, and then gastroenterologists take a bit of a step back and manage most of the medical problems, we're getting the best of both worlds here, as long as we're also communicating. And it's important to share what patients have said about the service. So we had, for example, one patient who said, I learned how to read food labels appropriately, how to manage deficiencies, foods to avoid, and how to avoid cross-contamination. These were topics I was unsure of before the appointment, and the dietitian explained these clearly. Another patient said, the doctor appointments don't cover the small details. I feel like this service brings together the medical tests, scans, appointments alongside the lifestyle changes. It's easy to get over the hold of the dietitian, and he's very knowledgeable. So I think this really shows how patients need this level of detail with diet. They need to have their questions answered when it comes to diet. And really when we used questionnaires with patients for feedback, what we managed to find out was that confidence to manage the condition through diet increased from 6.5 out of 10 to 9 out of 10 on average for those who'd seen the dietitian. So we're giving them confidence to manage their condition long-term out of primary and secondary care. So why do I think a dietetic-led celiac service is the future of celiac disease in a nutshell? As we've said, I think it's extremely cost-effective. It frees up a lot of gastroenterologist time and reduces unnecessary investigations. We can offer more support with diet, which is the cornerstone of treatment. Patients need help. This is not an easy diet. It's a permanent restrictive diet, and patients need help with it. Patients are very satisfied with this service, and it really strengthens that MDT working between doctors and dietitians, which is only going to help with patient outcomes. And it supports the implementation of a new non-biopsy approach where we can be that stepping stone between primary care and secondary care to support these patients throughout. And I think it's very evident that outpatient gastroenterology clinic waiting lists and endoscopy waiting lists are a big problem nationally and internationally. So I'm here to say that dietitians can help and want to help, and I think that's why this is the most successful formula we have to manage celiac disease going forward. So I want to say a big thank you to Sheffield for inviting me. Huge thanks to the whole team I have at Bradford who are extremely supportive and have facilitated all of this. Thank you to everyone for listening. I've got my email there if people want references and social media handles where I'm happy to take questions and interact. Thank you.
Thank you so much, Cristian. I don't think we've got time for questions. We might have to move on. Sure. But another really great example of dietitians being cost-effective, clinically effective and safe. So fantastic.
Thank you.
Thank you so much.